Hi, I'm Travis English. I work for Kaiser Permanente. In healthcare design circles, the concept of net zero often seems somewhat crazy and unattainable. Hospital energy is really high. Our national average is 200 kBTU per square foot per year. So a lot of architects and engineers and some healthcare owners have just very little hope that net zero is even a viable goal in the healthcare sector. This building is, I believe, the first demonstrated site net zero healthcare building in the United States. I've made that claim in public already, and as I've said before, if anyone listening here thinks that claim is bogus, please tell me and I will stop saying it. And just to include the nuance, this is a demonstrated net zero building, that is site energy. There have been a few healthcare buildings or designs with a publicly stated goal to be net zero. There have been some who stated their design was net zero. But we're going to talk about energy performance gap in a few minutes here. What I've learned about building energy is that design intent and reality often don't match. This was the third building we intended to be our first net zero building. It's located in Santa Rosa, California, 87,000 square feet. It is registered at the Living Building Challenge Net Zero Registry. And there's some key statistics up on the screen there. So first, let's tell some backstory here. First, if you're familiar with healthcare design, you may know that there's an ASHRAE standard called ASHRAE Standard 170 that has this table full of air change rates. All the exam rooms need to be 6 air changes, the x-ray rooms are 6 air changes, etc., etc. Now, we did not use this table in the design of the medical office building. If you use this table, it has a very big impact on HVAC energy, similar to a lab when you use high minimum ventilation rates. It really drives up your annual heating and cooling energy. What ASHRAE doesn't often advertise is that in healthcare clinics, your doctor's office or this building, which is probably not in a hospital, these rules are not written into the code. There are some folks who would like to see them written into the code, but right now they're not. So that makes this type of air change per hour approach more of a voluntary adoption when you're building clinic buildings, and we do not volunteer to adopt it. Now, that you could criticize us for that. It's worthy of criticism. But another thing ASHRAE doesn't often advertise is that they've actually looked at the research basis behind those air change rules and found it to be quite poor. This study came out last year on ASHRAE letterhead, and it actually says that 75% of healthcare ventilation requirements and about 95% of the air change requirements have no evidence basis, no clinical basis, and no rational basis. So there's not a very strong case for voluntary adoption of the air change standard, which is a very energy intense standard. This really is one of the keys sort of moving forward in healthcare. We're going to need to spend energy wisely, which means kind of at a minimum that we would spend energy on evidence-based or outcomes-based prescription. At the end, I'm going to come back to this. A lot of people have a lot of beliefs about air and health. Much of which is fear and myth and superstition or tradition or folklore or whatever you want to call it. And sadly, healthcare ventilation is one of the most non-scientific aspects of building engineering. We do have about 5 rooms where air quality and air movement is really important, but then we have these standards, the air change table, that cover hundreds of spaces with all of these non-evidence-based and really just sort of irrational prescriptions, 4 air changes per hour in exam rooms and 6 air changes in imaging rooms. Those numbers are really completely meaningless in terms of evidence. You might as well be hanging garlic in the door frames to ward off vampires. But in our industry, we are very, very stuck in those ways. So this is all a very long way of saying that Kaiser Permanente has not adopted to follow those air change rules in our clinics. We don't adopt ASHRAE Standard 170 anywhere that we're not required to by law. And that is fairly fundamental to this project. This building is a clinic with a variable volume system and a return plenum. If we were to follow the air change rules, the performance that we're talking about here just flat out wouldn't be possible. So I want to show you a couple years worth of buildings leading up to this. Most of the construction that we've done in the last 8 or 10 years are these clinic buildings, and starting in 2011 we've had a pretty aggressive energy program for those. Our first step is that we do energy models on every building, so we have energy targets for the buildings, and for outpatient buildings the target is EUI, or I'm sorry, the target is 50 EUI. And then, of course, we measure the results of every building and compare it to those energy models. So the buildings that we've opened between 2015 and 2017 compared to the buildings that we opened prior to 2012 are a full 50% lower in energy signature. That's great, right? That's a very good thing. On the other hand, our energy target for these clinic buildings is 50 EUI, and our energy models consistently show that or less, but the actual numbers come in higher, pretty consistently higher. There's a name for this, and it's called the energy performance gap. The energy performance gap is the gap between what our calculations say is going to happen with energy in the building and what really happens with energy in the buildings. And in most of our designs, that energy performance gap was somewhere between 50% and 100%. So to this building, our Santa Rosa Medical Office building. So now let me give you kind of another disclaimer here. When we say 0, we mean 5. I'm told that once a building is below about 10 EUI, you can call it a net zero building. And so we're going by that rule. The first patient was May of 2018. We started the M&V period in September. The 5 number is a September to September period. This building consumed 36.8 EUI of electricity, kBTU a square foot a year, and in the same period, our on-site solar production was 31.8. So net consumption was 5, and we round 5 to 0, I guess. This is the building exterior. It's a modular cladding system. You can see here. I'm not going to talk too much about that. We did incorporate these electrochromic windows. I'm not going to use the brand name, but these are the windows that lighten and darken like the opening scene from Blade Runner, but they do that automatically on a daily basis. And at this point, I'll mention our budget. The budget that we carry for our buildings does not include energy dollars. And we look at energy models as plus or minus 15 or 20% margin of error. So we generally are not going to issue budget changes for energy features because they're kind of high risk. This building did not have a particularly low or relatively low budget, but the question often comes up, how much extra money did you spend on the energy features? And the answer to that is $0.00. We did not allocate dollars for energy features on this project. In fact, the primary HVAC design strategy was an all-electric system. So it's a series of heat pumps, there's no chillers, and most importantly, no boilers, no gas line. On this site, the fact that we were able to eliminate the natural gas line and the piped heating distribution was $1 million savings to the project. So for HVAC, we have a north unit, south unit, east unit, west unit, and central unit. And then in the space, we have a combination of traditional VAV zones and thermal diffuser zones. But even in the traditional VAV zones, the heating is electric. Okay, so now I'm going to do a little diversion to another building and talk about the energy performance gap. Natural gas is a big recurring theme we've seen in the energy performance gap. I'm not giving you the name of this building, but on paper, these are 3 boilers that are 95% efficient. And in our design energy models, they're 95% efficient. And by the way, I'm inclined to believe the boiler manufacturers that these boilers are in fact built for 95% efficiency. But when we put them in buildings, we tend to oversize them and connect them to pumping systems and zone controls that introduce a whole lot of inefficiency. So this is a little study that we did on another building in the first winter, this winter, and this heating system is effectively functioning at 29% efficiency. It might be a little better than that. It might be up to 40 or 50% efficiency, but you can see that's a tremendous difference from what the energy model says, right? Whatever the energy model said, the natural gas consumption is going to be in this building. In reality, it's actually going to be 2 or 3 times that. So this is not unique, and this is also not an extreme example. We've been digging into energy performance gap, and in our experience, natural gas heating systems are a recurrent theme. I think this is another key moving forward in healthcare. I was a design engineer for a decade and some change, and I did designs on hundreds of buildings, hundreds. And I used the standard design tools, Tray 700, DO2, Energy Plus. But never once in my career did I collect the data to look at the heating load in the coldest week of winter. Never once in my career did I collect the data to look at the cooling load in the hottest month of summer. Never once did I validate the boiler plant efficiency or cooling plant efficiency. I designed hundreds of systems and I never did validation. And when I say it that way, it makes me sound like I'm a bad engineer, which may be true, but that's actually very normal. In our industry, nobody does validation. It is super rare. Even those of us who have done it, we've done it on 1 or 2 buildings. It's super rare. I think the good news is that the tools are now there and viable. Data-based commissioning is cheap and market ready. We're demanding it on every project in the last 2 years. And of course, the bad news comes with that. I've said before that data-based commissioning, doing data-based commissioning on the first project is like getting super depressed and then looking at yourself naked in the mirror. It really highlights system performance in a way that can be very, very uncomfortable. So let's go back to this building, Santa Rosa Medical Office Building, with its all-electric design. So the all-electric design is something that went really right here. Our energy performance gap is only 7%. Which is really, really low. If you've ever dealt with energy models versus actual consumption, you know, I assume a 15 or 20% margin of error in new construction as a rule. So an energy performance gap that's less than 10% is pretty great. And you can see in this case, actually the energy performance gap on our building was less than the energy performance gap on our solar panels, which is pretty cool. So right here at the end, let me tell you, this Santa Rosa Medical Office Building was a son of a bitch to commission. We had 3 types of temperature control zones, and we had some real issues with HVAC units switching over from heating to cooling. So it took us a full year to close out commissioning issues in the system. That's not to say we wouldn't do it again. There's definitely some lessons learned. I think the design and the control scheme was a little overcomplicated, but the energy performance is great. It is a site net zero building with the data to prove it. We have more clinics in design and construction right now, so I hope we're going to announce our 2nd and 3rd and 4th net zero buildings coming up soon in the coming years. But before we move out into discussion, I hope what I've highlighted here are 2 keys to net zero design in healthcare, and let me reiterate. First off, we have to make validation a rule, not an exception. Right? Imagine if you had 10,000 data points a day from cancer patients. You hooked them up to biometrics and you monitored 1,000 points on intervals and you created a huge data set. If that data set existed, you would be insane or even unethical to not look at it, to not mine it for data analytics and not learn from it. In a kind of less dramatic way, that's exactly what we do with energy systems in our buildings. Most of the buildings that we've built in the last 10 to 15 years have way more than 1,000 points of data. So 10,000 points of data per day is easy. And yet building after building after building after building, we ignore that data and we instead look at tools like Trace and Energy Plus and make our decisions based on that. That's crazy. If I've learned anything in the last 3 years of my life is that the design tools that I grew up with are frequently wrong. They can produce outputs that are vastly different than what happens in reality. And looking at the data that comes from reality is the biggest learning opportunity that I've ever seen. That is something that we have got to leverage in a huge way. The second thing that we've got to do in healthcare in particular is to stop hanging garlic around the building to ward off vampires, which is to say that our ventilation codes, we have got to move to more evidence-based ventilation measures. Many human beings have weird superstitions about air. My great-grandmother was a German immigrant from World War I, and she believed that if you slept with your windows open, you would catch a cold. And unfortunately, she moved to Tucson, Arizona. So as a kid, when we visited Granny's house in Tucson in the summer, it was horrible. The only time it got below 90 degrees was at night, and she wouldn't let you open the window because she was superstitious about air. That's so common, and it's so human. Just this month, we had an article in the ASHRAE Journal about COVID-19, and the article recommended, among other things, to run your HVAC systems 24/7. And unfortunately, the CDC picked up that list of recommendations and plopped it on their website. So right now on the CDC website, there's a recommendation that says building owners should consider running their HVAC systems 24/7 on account of the coronavirus. Now, I'm sure that was well-intentioned advice, But you got to think about it. Look at the evidence, right? The hypothesis is that running building systems at 24/7 would somehow prevent the spread of COVID-19. The evidence, Exhibit A is nothing. Exhibit B is nothing. The first witness is nobody. There's not a single shred of evidence that running your building systems at midnight is going to do any good for preventing COVID-19 transmission during the day. You might as well be hanging garlic on the door frames to ward off the vampires. And unfortunately, our industry, HVAC and healthcare, is shot through with unscientific thinking around ventilation. From all the air purification salesmen at the Sharper Image to the highest ASHRAE committees, we repeat all kinds of things about air and about air quality that just flat out doesn't hold up to the simplest level of investigation. Healthcare ventilation is the worst, right? And I'm not kidding here. I've heard it said, we need more air changes in the cancer center because, well, because why? Cancer doesn't have anything to do with the air, right? And then someone would say, well, the cancer patient might get something from the air during infusion, right? Okay. They might also get bit by a vampire. Those two risks have exactly the same level of evidence behind them. So in the long run, we're going to need to spend our energy, we're going to need to measure our energy performance. We're going to need to learn from what we measure, and then we need to spend our energy wisely at a minimum using evidence-based prescriptions wherever we can. That is all I got. Thanks.